Shashank ji, carry on.
Shashank, you are muted.
Thank you, Sundarlingam ji. Everyone, Swami Ayyappa is considered to be the Lord of Kali, and we offer our prayers to ease us out from these difficult times. I would invite Mr. Girish Nair to just say a few things about and enlighten you all about the Sabarimala Ayyappa Seva Samajam. Girish ji, please go ahead.
सबको मेरा प्रणाम. Myself Girish Nair. I am part of Sabarimala Ayyappa Seva Samajam and I am the district president for Mulund. Okay, so I begin with my speech. Swamiye Sharanam Ayyappa. That's how we address any meetings or we exchange pleasantries in form of Swami Sharanam Ayyappa every time we chant Lord Ayyappa's name. So, dear ladies and gentlemen, it gives me immense pleasure to introduce Sabarimala Ayyappa Seva Samajam, which is an organization of devotees of Sri Ayyappa worldwide. Sabarimala Ayyappa Seva Samajam, fondly known as SASS, SASS, has a vision to emerge as a truly representative body of Ayyappa devotees across the world to protect, preserve, and propagate Ayyappa Dharma as embodied by the holy shrine of Sabarimala, rising above castes, class, and language barriers, and through this work towards Hindu unity and national reconstruction. The basic mission of SASS is captured in 5 S, which denotes Satsang, Swadhyaya, Seva, Samarastha, and Sangarsha. In this, one of the 5 S is Seva. As we all know about a proverb, service to the mankind is a service to God. SASS has done a lot of Seva activities in various parts of the country, like distribution of free food packets, Ayurved kits, setting up of blood donation camp, etc. during this pandemic period, and it's an ongoing activity. SAS has active units in 13 states of India. Here are the key statistics about the organizational functioning. Number of Ayyappa Yogams, which is nothing but a weekly gathering of Ayyappa Sevaks. It's around 6,000 Yogams. And all put together, the participants that attend these Yogams would number around roughly to 1 lakh plus. We have a registered volunteers base of around 15,000. We conduct monthly Uttaram Puja. Uttaram is the birth star of Lord Ayyappa, and we perform Puja Archana at our respective homes. Currently, it numbers to around 2,500 households monthly. Apart from this, as you all may be aware of, the Sabarimala pilgrimage. So, to support the pilgrims who go there every year, Sabarimala Ayyappa Seva Samajam has set up main Ayyappa Seva Kendra. We call it as ASK, main ASKs in Kerala, at around 5 locations. The basic thing that is done here is nothing but providing free food, snacks, boiled medicated drinking water, ginger coffee, etc. Apart from this, there are another 250 Ayyappa Seva Kendras en route Sabarimala. So anyone who is traveling towards Sabarimala, some or the other place, they would find Sabarimala Ayyappa Seva Samajam offering all these free services. It's one way of service to the Lord. Today, we would like to thank and welcome all the members of Sabarimala Ayyappa Seva Samajam of Kokan Pranth, more specifically Girgaon district team under the leadership of Sri Shaji, for hosting this important session on complete COVID management. We would also like to welcome all the distinguished dignitaries from the medical fraternity and all the other participants and Ayyappa Sevaks on this group. Good luck. Swami Sharanayappa.
Kirishi, thank you very much for your introduction on SASS, Sabarimala Ayyappa Seva Samajam. With the Lord's blessings, we will just start off with our program in troubled times. Somebody's mic seems on. Hello, everyone. These are indeed difficult times where our lives are revolving around the evolving virus. Mankind has faced several pandemics in the past and has emerged triumphant over these diseases. Leprosy, a feared disease that features in the Old Testament, is still prevalent but curable with prolonged treatment. We have faced the Black Death bubonic plague from 1346 to 1353, wherein over 50 million people had died. We overcame the speckled monster, smallpox, in the 1800s. The death rate then was 400,000. According to the World Health Organization, smallpox has been successfully eradicated worldwide. Avian influenza, not just one for the birds, is common, and several major outbreaks have occurred sporadically worldwide since the disease was first recorded in Italy in 1878. It took until 1955 to discover that the visiting virus causing bird flu was an influenza type A virus. Polio, the most dreaded childhood disease of the 1940s, 1950s. Polio vaccination is key to global eradication. Ebola is on the radar. It was first discovered in 1976, and bats are thought to be the most likely reservoir of the virus. The virus spreads to humans and from human to human. Direct contact through broken skin or mucous membranes with an infected person or animal, either living or dead, or with other objects such as contaminated needles and syringes, is the most common way Ebola is spread. Causes of sexual transmission from people who have survived the virus have also been reported months after their recovery. The risk is low as long as sensible precautions are taken. Mankind has also faced the onslaught of cholera and malaria and HIV severely in 1981. Not many years ago, we were affected by SARS, severe acute respiratory syndrome, which is spread through close contact with infectious droplets released during a cough or sneeze. SARS started in Asia, and researchers have identified the most likely source as wild Chinese horseshoe bats that had been caught and brought to the market. These bats harbored a SARS-like virus that subsequently infected civets before mutating, which meant that humans were now susceptible to the virus. Within a year, the infection had spread to more than 24 countries before it was contained through public health measurements. SARS prepared us for MERS. MERS is Middle East Respiratory Syndrome, but it did not prepare us for the COVID-19 that we are facing right now. There has been a small number of cases reported, mostly from laboratory accidents or possibly through animal to human transmission in Guangdong, China. MERS is another coronavirus infection that can be fatal. A total of 2553 laboratory confirmed cases of MERS were reported up until the end of 15th Jan 2020. The majority of cases were reported in Saudi Arabia and are linked to contact with camels, their dung, milk, or meat. Mares can cause severe respiratory and kidney failure. Late 2019 and early 2020, SARS-CoV-2 started to create havoc around the world. Initially, experts thought it was just another flu virus, but the speed and ease of its spread, coupled with its high fatality rates, quickly proved all of us wrong. The impact of the condition caused by SARS-CoV-2, called COVID-19, not only forced unprecedented lockdowns worldwide, but its social and economic impacts will be felt for years to come. We have all gathered in this virtual meeting room to discuss SARS-CoV-2 or COVID. You must think, why this topic that is already being discussed day in and day out on every news channel, website, and social media. You will notice I called it COVID and not COVID-19. The reason is because both the illness and the virus causing it has considerably evolved since 2019. All over the world, doctors are learning newer and newer things about the disease. Some of the information that was valid some months ago is no longer valid today. The time has come when these issues matters not only to doctors but also to non-medical persons like us. Each one of us knows someone who has been infected. So getting correct, updated information on COVID is no longer optional but necessary even for us. Our esteemed guest doctors will agree with me when I say that today there are many people who consider themselves as supermen and indulge in false bravado. They don't take the COVID precautions, posing a danger to themselves and others. On the other hand, there are people who will sneeze once, start panicking, and run to their doctor with a bag full of unnecessary blood tests, reports, and HRCT scans. Our medical experts in today's seminar will update us on the latest information on our enemy, the coronavirus, the symptoms and danger signs we should look out for, the necessary tests, and the treatment of COVID. They will also guide us on supportive treatment like nutrition, vitamins, and other supplements, yoga and exercise, as also for vaccination and blood donation. They are very much pleased to answer our questions and clear our misunderstandings. At the end, we may not be qualified to start treating COVID patients, but we will have enough knowledge to remain safe and help our doctors help us. With that, allow me to introduce our renowned panel of physicians. We have with us Dr. Rajesh Parekh, and he is a director with Jaslok Hospital, and in the center of the entire COVID dilemma that we are facing in Mumbai, we have Jigishu Divetia from Tata Memorial Hospital, and we have Hemant Shah from his ICU office in USA. Let me start by introducing Dr. Rajesh Parekh, who will be starting with his first informative talk. Dr. Rajesh Parekh is the Director of Medical Research and Honorary Consultant Neuropsychiatrist at the Jaslok Hospital and Research Center. He is also Adjunct Professor of Psychiatry at the University of Iowa, USA. He trained at the St. G.S. Medical College and the KEM Hospital, Mumbai, and the Johns Hopkins University School of Medicine, Baltimore, USA. He has over 125 publications in leading journals such as Lancet, American Journal of Psychiatry, British Journal of Psychiatry, Archives of General Psychiatry, Archives of Neurology, Stroke, etc. He has written 10 book chapters in national and international texts. He has been invited to teach at the Harvard Medical School in Boston, the Johns Hopkins University School of Medicine, Baltimore, the Institute for Research in Neuroscience and Neuropsychiatry in France, and has taught at the GS Medical College in Mumbai. Dr. Parekh has had a distinguished academic record with several awards, including the Bombay Psychiatry Society President's Award 3 times, the Tilak Venkoba Rao Award of the Indian Psychiatry Society, the S.M. Lalla Oration of the Bombay Psychiatry Society, Distinguished Alumnus Award, the Xavier's Ratna of the St. Xavier's High School, and also of St. Xavier's College, Mumbai. He is a university rank holder in all exams in psychiatry and stood all India in the national and stood first in all India in the national board exams. He has been on the editorial board of Dialogues in Clinical Neurosciences for over 20 years and is the editor of the Just Look e-bulletin for the past 5 years. He has cumulatively won over 200 awards in activities as diverse as photography, painting, general knowledge, quizzing, writing, and debating. He is an author to many of books and also to books related to COVID and the virus. I now would like Dr. Rajesh Parekh to please take over and help all of us out, ease out, weed out the myths surrounding this deadly coronavirus so that we feel at peace at all times. Please, Dr. Rajesh Parekh.
Thank you, Mr. Shashank Shah, for your generous introduction. And thank you also to Mr. Girish Nair for hosting this program and inviting me to be here. I have been blessed to have visited the Sabarimala temple about 20 years ago. We went there for darshan for a day and have experienced the sublime atmosphere within the temple and around the complex. And I'd like to congratulate y'all for the wonderful work that y'all are doing across the world. To get on with the presentation, I need to share my screen with you, and I'll do that in a minute. No matter how much I practice it, I never get it perfect, but let's hope it works. Okay, that should be my entire screen, and there it is. And I hope this is now visible to you. I'm assuming my screen is on.
You'll have to share it present now.
Oh, I've not shared it yet. I'm sorry.
Oh.
My apologies. There is a shared screen mark, and that's the one I hit, but we'll do it again. One thing we learned in Xavier's school, you know, all my fellow Xavierites are here, so happy to be with you all. And let's say...
yeah, it's coming on, yeah, proper.
And this is on now?
Yeah, that's all.
Is the first slide on, which is 100 years of pandemics?
Yes.
Okay, great. So I'm just continuing from where Mr. Shashank Shah left off. He gave us an excellent historical perspective of pandemics. But before we get on to the details, I thought just some terms might be helpful. So an epidemic disease is when a disease suddenly comes up in large numbers in a certain population. Now, when that disease lingers on and resurfaces periodically, it is said to be endemic. And when the epidemic disease spreads across the world, it is said to be pandemic. Thus, COVID-19 began as a small epidemic in Wuhan in China, rapidly became a pandemic, and some experts have postulated that it will eventually become endemic. And just to give you some numbers on what Mr. Shashank Shah told us. So in the Spanish flu of 1918, 1919, about 100 years ago, there were about 100 million deaths. The earlier estimates were more than 50 million. But now with genetic studies done on some of the bodies that have been autopsied, got out of the Alaskan permafrost, it appears that it would have been about 100 billion people at that time. That in today's population equivalence, by the way, is 450 million people. That's more than the entire population of North America, Canada, USA, Mexico, much more than that. Were just wiped out from our planet 100 billion years ago. And then the Asian flu, the Hong Kong flu, the swine flu, which we will all probably recollect, and with COVID-19. With COVID-19, we see that the deaths so far are over 3 million. And just to point out some parallels between the pandemic that occurred 100 years ago and the one that we are witnessing today. I apologize. Yeah. And here we see that had 3 waves. This was the first wave. And then a few months later, as has happened in our country today, there was a ferocious second wave, far greater in its intensity than the first. And at the end of that, there was a third wave, not as bad as the second wave, but still much worse than the first wave. So this just gives us an idea of how these pandemics behave. They behave in a way like tsunami waves. And the second wave, 100 years ago, was triggered by mutations of the virus and soldiers returning home after World War I. Now let's move to what's happened more recently. So as we all know, all of what we are facing today began with a single patient in a single market, in a single city in China. The Wuhan market sells over 140 species of animals. Most of them are illegal, even within China. And these, have the whole range from bats to larger animals like horses and donkeys. And the Chinese believe, for some reason, that medicinally it is good to consume freshly slaughtered meat. And so these animals are slaughtered right there in the market. And it is believed that one such animal, in all probability a bat, possibly a pangolin, jumped onto a human, and the first patient contracted the disease that we now call COVID-19. So this happened sometime in end November, early December. Just, I think 3 days ago, the Chinese finally gave a name to patient 0. Since we like to protect the identity of all our patients, let's just call them patient 0. 8th December, that patient sought treatment. But 31st December, the WHO office was informed by Chinese officials of these cases. Now, here's something I would like to point out. Notice the enormous delay between the first patient and the WHO office being informed. Now, by health treaties across the world, anytime a bizarre illness, unknown previously, comes up, the WHO, local WHO office is to be notified immediately. But the Chinese took a long time to inform the WHO. They had already done that in the SARS, where they took even longer to inform the WHO, and they did it again. So precious time was lost in the beginning, during which the pandemic moved from one individual across the world. So on the 30th of Jan, the WHO declared a global emergency. Sometime in February, the virus got a name and the disease got a name. By mid-February, half of China was under a lockdown. And by the end of December, the sea market was barricaded, ID cards were required, but only in January of 2021 was the WHO permitted to come and investigate the origins of the illness. Now, this is unprecedented. Unprecedented except for what the Chinese did with SARS. Normally, the WHO moves in with a team immediately. So you can imagine they waited a year and 3 months before giving WHO access. And that was also very highly limited access. They did not give them access to what we call primary resources. They only gave them access to Chinese data. So there's something quite clearly the Chinese do not want the world to know. And, in less than 80 days, actually about 42 days, the virus spread from Wuhan in central China across the world. And as of yesterday evening, we see that there have been 156 million confirmed cases of COVID. There have been 3 million deaths, and the vaccines will come to a bit later. And most of you have now seen this dreaded image. So I'll just go through this very quickly. Suffice it to know that the coronavirus has no other function other than to replicate. So some people are not even sure. Scientists are divided on whether it is living or whether it is inanimate. So it has a coat, and within that is RNA, which is like DNA and helps the virus to replicate. And by now we've all heard of the dreaded S protein, the glycoprotein. And this protein acts like a key which fits into a lock called the ACE2 receptor, which is located on several organs of our body, but predominantly in the lungs. Human lungs are rich in ACE2 receptors, adults more than children, men more than women, and that explains to some degree why the prevalence of the disease has, at least until recently, been confined to adult and senior males. But of course, women have also been dying of COVID-19. Now, a quick run through the disease. As we know, it's a zoonotic illness, means it goes from animals to humans and back and forth again. The incubation period can vary up to 2 weeks. But here's the dangerous thing. Somebody can be infectious for 1 to 2 days prior to symptom onset. That means with no symptoms and the individual not even suspecting that he or she may harbor the virus, they can infect many other people, which results in a related concept known as R0 or R0. And R0 is how quickly does the virus double or even triple. Some of us may be familiar with the old parable of the poor man who went to the king, and the king said, I'll give you a boon. You ask whatever you want and you will get it. And he said, all I want is a grain of rice on a chessboard. And on the second square, I want 2. And on the third, I want 4, and so on. And not all the rice in the world, leave alone the kingdom, could have filled up that chessboard. In other words, with a R0 of about 2.5, it's just a question of 22 steps from the earth to the moon. And that is why this disease has spread so rapidly. Its R0 was around 2.4, and of course now it has varied in the waves. This is again something important for all of us to know, that 80% of the cases are mild. It's barely like a flu. People don't even realize they're ill. About 15% are severe, 5% are critical. Males are at greater risk than females. People who are over 65 years were at far greater risk, at least in the first wave. And in all waves, comorbidities, meaning other illnesses that people have, make it very risky for them. What are the symptoms? I think by now all of us know the symptoms, so I'll just quickly run over them. The systemic symptoms, fever, fatigue. Then, as I mentioned, the ACE2 receptors are on many organs in the body. So you can get symptoms in the kidneys, in the intestines, in the brain, loss of taste and smell, respiratory symptoms, of course. And then there are the circulatory systems, the white blood cells which defend us against the virus also get compromised. And this is just the frequency of the symptoms. As you can see, headache, fever, dry cough, muscle aches are the common symptoms. Not as people like to think, it's sore throat and runny nose. So the symptom profile has also been changing with time. And this is the most recent profile. Now, here are the fatality rates, the mortality rates. So if there is no comorbid condition, then it's about 1.4%. So quite clearly, the vast majority of people who contract COVID-19 emerge successful from it. However, this is how the numbers add up. If somebody has cardiovascular disease, that is any type of heart disease, then the mortality is 13.2%. With diabetes, 9.2%. With blood pressure, 8.4%. With chronic respiratory disease, which is diseases which often arise from smoking, 8%, and in cancer, 7.6%. Now, we're all familiar with the RT-PCR test. Currently, it's the gold standard for confirming a diagnosis. And then there are blood tests and, of course, X-rays, CT scans, a bunch of blood tests. Just important that we should understand that the RT-PCR test has a false negative rate of about 35%, which means if the test is administered to 100 people who are suffering from COVID-19, about 35 will falsely appear negative. And then these people, believing that they have no illness, might be less cautious and infect others. Let us quickly run through treatments. I won't get into the details of this because my colleagues, Dr. Hemant Shah, Dr. Jiggy Divakya, are going to touch upon this. And besides, they have first-hand experience, so they are more qualified than I am because they use some of this all the time. And I've just made a comprehensive list. There is considerable controversy between regulatory bodies across the world on the usage of these, and more important, when to use it and in whom to use it. But as I mentioned, my colleagues will deal with that. And of course, we can even address that in your question answers. So the anticoagulation measures. Now, these have shown to be fairly successful in patients in whom it is warranted. It's again something that should be carried out under medical supervision in hospitals, because one of the things that can happen, if you recollect, in the systemic part of the disease is that clots can form, and then they can result in strokes in the brain, in the heart, and so giving something that thins the blood, such as heparin, and there are other drugs, is helpful. But once again, it's to be done under medical supervision. It's a two-edged weapon. Somebody can bleed, get a hemorrhagic stroke. So it's to be used very, very judiciously. And now there are the antiviral drugs, remdesivir, about which a lot has been talked. These are repurposed drugs. You see, normally to have a drug go through clinical trial can take anywhere from 7 to 10 years. We didn't have that kind of time, but there were drugs which had been seen, at least in the laboratory, to be antiviral, and so they were repurposed. Now, remdesivir was found to be effective in the laboratory against viruses. It was initially, they thought of marketing it for Ebola, but it was not even proven to be effective for Ebola. Initially, the early data showed that it reduces hospital stay by about 3 days, though has no effect on mortality. Subsequent data from, say, the WHO trial, the Solidarity trial, which looked at a lot of these drugs, did not show any impressive benefit. So it is controversial. And so are all these other drugs, excuse me, which are all repurposed drugs, with the exception of apilimont. You know, this is a drug. It's the first time that an antibiotic or antiviral has been developed by artificial intelligence. But again, no compelling data to support it, no compelling data to support the use of azithromycin, though some people believe it helps. And of course, we all heard of the hue and cry over hydroxychloroquine, which is now proven to be ineffective. These are antiparasitic drugs. Recently, there was a trial in Lancet showing some benefit with ivermectin, a drug which is used for intestinal worms and other parasites. But again, there is some degree of multiple opinions on how and when it should be used, and if it should be used at all. And then you have the drugs which are called immunomodulators. So, you know, the primary thing when the virus enters the body is the immune response. And sometimes the immune response is not adequate. Sometimes it is more than what is required, what is known as the cytokine storm, and it actually damages the body's organs. And so there is a role for drugs which modulate the immune system, but such as steroids, dexamethasone, easily available, inexpensive. In parts of India, one tablet can cost as little as 25 paise. I don't know anything in the country that costs 25 paise these days. And it's been used for a long time. And however, the really important thing is to use it on the right person in the right dose at the right time. Given too early, it may suppress the immune system and the disease could get worse. So this again has to be done ideally in a hospital under medical supervision and not just randomly taken at home. And then there are other drugs. You may have been hearing about tocilizumab. Again, a bit controversial, different opinions. Some say that it reduces hospital stay. A research study in England showed that. But I'm not aware, to the best of my knowledge, of a single study showing that it has any benefit on mortality. And then there are other immunomodulators. We didn't go into those details because they're under investigation. We all heard about convalescent plasma. When we wrote our book 14 months ago, in the month of February, it was, by the way, the first book on COVID-19 in the world. We had already discussed HCQ, which we thought would not work out. We had put a query on convalescent plasma because it did help some patients of SARS. But, as Mr. Shashank Shah pointed out, this is a completely different disease. And the ICMR in India, the Indian Council of Medical Research, conducted a large multicentric study, and it showed no effect whatsoever. And then there are newer drugs such as monoclonal antibodies. They are showing some effect, but I would leave it to my colleagues to discuss them if they find it appropriate. Now let's come to vaccines. So there has been, as we are all aware, a tremendous vaccine race. In our book, the vaccine book, we've actually described this race the way a commentator would describe a race, starting with who are the contenders, what happened in the first lap, the second lap, the third lap, all that happened, the sideshow, the circus, everything we've covered. They started initially with about 240 vaccines. Then, there are different phases in research, and you have to clear one hurdle to go on to the next, and then to the third, and to the fourth. And so there are now 8 fully approved vaccines across the world. 4 vaccines were abandoned after the trials. And here are some of these vaccines. We all know about them now. The Covishield, the Covaxin. I won't get into the details of that. I'll leave that for question answers if people are interested in any of these vaccines in particular. But these are the 2 vaccines currently available in the country. And then you have, of course, the mRNA-based vaccines. A lot has been written about them. The Pfizer vaccine, the Pfizer-BioNTech vaccine, actually, and the Moderna vaccine. Now, these are vaccines which use just a part of the virus, sometimes synthetically derived, which is a bit of the RNA structure, and that then sensitizes the body to fight it. So how do vaccines work? Vaccines work in the way that you have a military exercise, a dummy war, a inactivated virus, a dead virus, or sometimes what we call an attenuated virus, which is a very weak virus, or subunits of a virus are introduced into the body. The immune system recognizes this as a foreign body and gets into overdrive and has now had a rehearsal. So when the actual virus comes in, it is fully prepared to deal with it. Another thing I'd like to mention at this point is the WHO considers 50% efficacy as good enough in a pandemic. All of the vaccines that we have exceed this by far. They range from 70% to even as high as 95% efficacy. So all vaccines are good. The interesting thing about these vaccines is because we should feel positive. There is so much of negativity related to the pandemic. We should feel positive. We should feel proud that
Dr.
These
Parikh, sorry to
vaccines, which
interrupt
can
you.
normally take
Dr.
8
Parikh,
to
sorry
12
to interrupt.
years to develop, have been done so rapidly. Moderna, for example, within 2 days of the Chinese releasing the DNA sequence, the RNA sequence of the virus, were able to synthesize it. And within 63 days, the first patient was dosed. They had a first trial of 8 patients, which showed impressive results. I mean, this is unprecedented. This process normally would take about 10 years. So yes, while there is cause for concern, but there's also cause for a lot of hope. We have technology which we never had before. Brilliant minds are working on this even as we speak. So better vaccines are coming out. And this is the Sputnik vaccine. It's likely to come into our country, the Johnson & Johnson vaccine. So these are the 6 vaccines,
Dr. Parikh, can you please share your screen? You lost the ability to share the screen.
Now, quickly, let's get into common myths. So all of these are myths. See, there is no cure today. Let's be very clear.
Dr. Parikh, just a minute.
Absolutely proven cure. And some of the other things that are being done in the absence of a cure are not necessarily helpful. So I've covered some of these myths. I don't have to sort of read them aloud to you. And these are just some of them. There's so many more. And then there is a lot of misinformation going around.
Dr. Parikh, your
conspiracy
presentation
theories.
is not being
fact,
seen.
Within 3
Dr.
months
Parikh?
of the onset of the pandemic, the WHO warned of an infodemic, which they said is almost as dangerous as the pandemic, which is all the misinformation that is going around. Is it a creation of Wuhan's Institute of Virology? Well, the case is not completely closed as yet. Data so far indicates it's unlikely. But right now, that's not something that matters importantly to all of us. We all have to stay safe, stay alive, keep our fellow citizens or fellow inhabitants of the planet alive. And with time, of course, the real truth will come out. Some have looked at books. I'm sure a lot of people have seen Contagion now. So some are saying, oh, it was already talked of. So somewhere somebody knew it was coming. Tragically, the Bill and Melinda Gates Foundation has also been accused of doing it. They're the world's largest philanthropic organization. They are contributing a lot to contain the pandemic. And it is postulated that they wanted to make a profit. Even if they were to make a profit, very unlikely. And they have done a lot in this pandemic and also in the polio, in controlling polio. Then, of course, 5G has been blamed. Clouds have been blamed. All kinds of things. Many, many, many more conspiracy theories. I thought I'd just touch upon it to sensitize people not to believe everything that you get on WhatsApp. And here is one of the greatest heroes of this pandemic. In fact, we've dedicated.
Dr. Parikh, your
our book on the
presentation cannot be
coronavirus, which I
seen. Can
mentioned
you
to we wrote in February
share the
2020,
presentation?
when
Dr. Parikh?
very few cases in the world, we realized that this is going to be very dangerous and could spread around the world. And we dedicated our book to Dr. Li Wenliang. He was an ophthalmologist. He worked in Wuhan Central Hospital. He saw some cases. And on a group which is like WhatsApp.
That is okay, audience. Let him continue. We can still hear him, which is good enough.
He only warned his medical school classmates, people who went to medical school with him, a handful of them, that there is a strange illness. We should all be careful. It spreads. The police came down. They almost arrested him. He went through a very, very rough time. And right on the front lines, like many, many more after him, he contracted the virus. And then on the 7th of February, he passed away, leaving behind a baby and his pregnant wife, who has now had a second child. We've written a chapter on him and dedicated our book to him. I'm highlighting Dr. Li Wenliang because throughout history and even in this pandemic, often the people who speak out are silenced, arrested, and shooting the messenger is the most dangerous thing one can do when the messenger is trying to warn us to do something for our own good. Also, the pandemic has brought up social media never before. Some great things have happened. Telemedicine. I didn't own a cell phone till a year and a half ago. My colleagues were astonished that I managed to live without a cell phone. Luckily, I got one just before the pandemic started. Today, I see all of my patients through telemedicine, and I was surprised to find out how much they love it. Some of them are asking me whether we could continue like this. They don't have to fly down to Bombay, say from Calcutta. They don't have to wait in the clinic. They can consult me from the home. And maybe once in a while, I might see them once things are under control. But telemedicine has been proven to be a great boon. Of course, social media has helped in spreading useful information, because information about SARS-CoV genome, symptoms, treatment spread so rapidly in a way that helped the world. The outbreak is being tracked. I personally look at this, the Johns Hopkins board, which updates every 15 minutes on what the current situation is in the world. Also, it helped in contact tracing, so we cut the transmission rates through that. India also had a great app for that. And the vaccine delivery, now, COVID has not worked very well, but more often than not, it has worked. It's new, it's crashed. And most important, social media has allowed us to connect with people despite social distancing. And in fact, I'm now more connected I'm connected with more people than I was even before the pandemic, thanks to social media. We're chatting today because of social media. There has been a negative side to it too. The Chinese Politburo censored information. This was the infodemic that I spoke of earlier. And then there has been a lot of cybercrime. There has been, this anger against Asian people, racism, trolling. And besides, people have started using social media excessively, and that has been shown to increase depression and anxiety across the world. While talking about the medical aspects, I'll just quickly cover the economics. This is the huge loss, global loss, and that's only so far, $12 trillion to the GDP. And these are just for those who are interested, the changes in different regions. I'm sure this talk will be available on YouTube or on other channels. And for those of you who are interested in these details of what's happening in different countries, you could look at it, but by the time you see it, it could change again. Now, finally, so, it's not as if COVID-19 is the only disease in the world. It is the disease we are focused on. Unfortunately, a lot of other diseases have been eclipsed. About 3 million people have died of COVID-19 in approximately a year and a half. But every year, 17 million people die of cardiovascular diseases, 10 million people die of cancer, 5 million people die of tuberculosis, HIV, other infections. And unfortunately, because people are hesitant to go to hospitals currently, some of these patients are coming at end stage, and therefore these mortalities are increasing. Then there's a danger of new infections. In the beginning, Mr. Shashank said, I don't want to call it COVID-19. The WHO and Johns Hopkins actually came up with a concept, 2018, I think, called Disease X. This was a pandemic which comes from one individual and spreads rapidly, leaving 67 million deaths. They ran the scenario and then just halted it because it was just showing that huge populations are getting wiped out. When this pandemic came, most people said, oh, this is the disease X we've been waiting for. In some ways it is, but disease X could be even worse than this. So we have to be prepared. And then let us not forget the other problem, that viruses are outsmarting antiviral agents and also antibiotics. We already have a problem of multi-drug resistance in illnesses like tuberculosis, and we can have extensive drug resistance. And what is worse, we can have totally drug resistant, and that we're seeing in tuberculosis. Let us hope and pray that this doesn't happen with the present virus. I think I've come to my last 2 or 3 slides. We should also think beyond vaccination. So in our first book on the coronavirus and in the second book on vaccination, we coined the term cultural extinction event. The world has been through 5 physical extinctions where more than 90% of existent species got wiped out. And we coined the word that this is the first cultural extinction event where the entire culture of the world is changing dramatically. A process which might have happened slowly is happening fast, whether it's work from home, study from home, lockdowns. Our way of life is going to change. TCS, one of the largest employers in the world, has already started selling off its real estate. They are anticipating that about 70% of their staff will be able to work from home after the pandemic. So some of the changes induced by the pandemic are undoubtedly here to stay. And then, finally, the pandemic has also taught us what is essential. We've heard the word essential services used all the time, essential goods, essential workers. But at a deeper level, at a personal level, the pandemic has given us time to sit back and reprioritize our lives. What is truly essential? Is it the promotion? Is it the paycheck? Is it social recognition? Or is it our friends, our closest friends, such as my dear friends from school, many of whom I've rediscovered in the pandemic, our own family, our relatives? Some of us, I'm sure, have discovered that these are the things that matter. And good health, of course, is what matters, something we usually take for granted. Nutrition. So beyond vaccination, we have to reprioritize our lives. Also, we have learned that we are only safe as the weakest amongst us. In our first book, we wrote that as long as one of us is unsafe, all of us are unsafe. The pandemic cannot be controlled by spending billions in the United States and spending just thousands in an African country, because it will go around and come back. And then there are the other things of the pandemic, which we should not forget, that close to 300 million will suffer from hunger. About 270 million have already suffered. These numbers are likely to go up. Let us never forget the saddest episode in our history after partition, and that is what happened to our migrant workers who were sprayed with bleach, who were given a few hours, and they had to walk. They actually people who walked from Mumbai to Punjab. There are other tragedies within the bigger tragedy. And we've also learned that politics, power, money cannot save us from a pandemic. You could have the US. Look at the US, a country with the biggest GDP in the world, with the greatest Nobel laureates in the world, with the greatest technology in the world, but misguided leadership, and more important, there being an absence of social equity in which the poorest get treatment, which is not totally different from the wealthiest, exposed all this, and the pandemic went around. But what can help us, of course, is science, research, and frontline workers. The ability of frontline workers, like my colleagues on this program, I know, and I can call him Hemant because he's junior to me in school, though he is now doing brilliantly in the United States. He is, even now, I'm sure, I wouldn't be surprised if while I was talking, he was seeing patients. But as soon as he finishes this talk, he'll be back with his patients. So frontline workers have kept the world going. More than 1 million healthcare workers have been infected. And hundreds of thousands have died. We don't even have the real numbers. And the last slide is going to be a dedication to them. And then again, what has emerged is the role of artificial intelligence. Sometimes artificial intelligence can be more human-centered than human beings themselves, because a computer doesn't look at caste, at religion, at your bank balance. An artificial intelligence algorithm looks at where the need is greatest, where the seroprevalence is poorest. It would want vaccines to go. And AI behaves differently from humans, from politicians, from many other factors which determine who gets treatment and who doesn't. So artificial intelligence is here to stay. And finally, I'd like to end with this small, less than a minute's video, a tribute to our frontline workers, like my colleagues who will now follow me. And here it is. Yes, that's it.
Thank you very much, Dr. Rajesh Parekh, for a very elaborate description about the virus, its effects, about the vaccination that's available, and the precautions and care that we have to take during these trying times. I would like to now call upon Dr. Jigishu Divetia for his presentation and talk about this deadly virus. Dr. Divetia is an MD, FIS, CCM, FCCM, professor and head Department of Anesthesiology, Critical Care and Pain at the Tata Memorial Hospital, Mumbai. He's a postgraduate diploma in Medico-Legal Systems, Symbiosis Center of Healthcare, Pune, 2001. He has been the past president of the Indian Society of Critical Care Medicine. He's the past editor-in-chief of the Indian Journal of Anesthesia. He's the president Society of Onco Anesthesia and Perioperative Care. He is the chairman, Hospital Infection Control Committee, Tata Memorial Hospital. He has coordinated the framing of the Tata Memorial Hospital policy for infection control during the COVID-19 pandemic. He is member of the COVID Action Group of the Tata Memorial Hospital. He is a co-author of guidelines for COVID-19 management by the Indian Society of Critical Care Medicine, All India Difficult Airway Association, and Indian Resuscitation Council. Co-author of a review article on ICU management of COVID-19 published in Lancet Respiratory Medicine in April 2020. He has over 150 publications to his credit in national and international journals. And there has been his presentations in several international, national and state conferences. I present Dr. Divetia for his important message for all of us. Dr. Divetia.
Yeah, good evening, and thank you, Shashank, for this opportunity. And I would like to thank Shashank, of course, and Ayyappa Sabarimala Seva Sangh for this wonderful initiative. Now, the reason I'm going to talk to you about management of COVID-19 is not so that you can treat yourself or others at home. In any case, with like Rajesh said, with social media and WhatsApp, everyone is a COVID specialist in India today. So even your rickshawala, your taxiwala, your doodwala, everyone seems to know everything about COVID-19. But I thought I'll just tell you how COVID-19 is generally managed based on the guidelines that have been laid down, say, by the All India Institute of Medical Sciences and in our own institution. Okay, and I'll just try and hopefully help us understand that, while this is a bad disease, this is a pandemic, it is something terrible which is going around the world, we still should not panic, and there is a lot we can do, and a lot of us will just eventually get through this, and eventually we will overcome this problem. Okay, so I think before we do anything, I think there's 3 or 4 very simple messages that we must protect ourselves and we must take precautions against spreading COVID-19. Today, the situation that we are seeing, the situation that we are in, we've got 5, 6, 7 times the number of cases that we had in the first wave. Governments can ramp up hospital capacity only so much. Hospitals can only buy so many ventilators. But unless the load comes down, hospitals will not be able to cope. Doctors will not be able to cope. And the only way that the load can come down, the patient load, the sickness load can come down, is if people, all of us, all over the country and all over the world, maintain simple practices which will protect us and protect everyone else. That is vaccination, social distancing, wearing a mask, and if you're at office, or if you're at work, and if you're eating together in a group, minimum of mask time while eating, and of course hand washing, and no unnecessary travel or socializing or something like that, at least for this current phase that we are in. Okay, So having said that, let's just talk about how this sort of, what we know about how this disease manifests itself. So see, this is the virus, then green, this green cone over here. So the virus is present in our body for about 8 to 10 days. But very importantly, the symptoms start after a period of about 2 days. So for 2 days, we have the virus in us and we are actually shedding that virus and infecting others. And it's only after a couple of days that we start getting symptoms, and that's when we know that we are sick. But we are actually infecting people even for a couple of days before we are sick. And that is why it is important that everyone have masks, because we could be carrying the virus and spreading it without even knowing it, right? So if everyone is masked, everyone is protected. So then you start getting symptoms, and then as the symptoms go on, as time goes on, over the first week or so, the amount of virus in the body reduces. At this time, the oxygen saturation, the amount of oxygen in our lungs is quite good, and there is no problem. And 95% of patients will get better in these 10 days, and nothing more is likely to happen. Now, why does the virus go down? Because the body starts mounting an immune response, right? So initially, of course, when there's no virus, there's no immune response. But as the virus stays in the body, the immune response of the body starts increasing, right? Now, by and large, if at this point over here, everything is fine and there is absolutely no problem and patients get better. In a few patients, not in all patients, okay, just about 5, 10%, 15% of patients, the body's immune response, or the inflammatory response that we say, it goes on increasing beyond what is required to tame the virus. So this is an sort of exaggerated response or a uncontrolled response. And when that starts happening, the lungs start getting damaged and other organs start getting damaged. And here is when you start getting signs of your oxygen dropping. And as your inflammatory response keeps increasing, and this usually starts happening after around the 10th day, you'll find that the oxygen levels in the body keep on dropping. And if you're not able to tame the host response, control the host response, then the saturation drops even further, and that's when things get pretty dangerous for the patient. So in the first few days, the treatment, almost nothing is required except maybe something against the virus. In the next 2 weeks, in the second 2 weeks, what you need is something to calm down the immune response of the body, to tone it down, not completely knock it out, because a little response is still required to fight infection, but you need to reduce the host response so that the patient eventually gets better. So this is roughly our philosophy when we are looking at treatment of patients with COVID-19. So now everyone knows about home isolation. So who should get isolated at home? And bulk of the patients, bulk of the people who are affected can easily be managed at home. So these are patients who we say have mild disease. They either have no symptoms, but you just get a RT-PCR test done because you were exposed to someone who had the virus and a RT-PCR comes positive. So you have the virus, right? But you don't have symptoms, or you have very mild symptoms like a fever, like almost exactly what you get when you had the flu in the old days, right? So you just have fever, maybe sore throat, a body ache, right? Nasal congestions. Nowadays, we also recognize that stomach upset sort of thing, gastrointestinal diarrhea or something happens. But there is no breathlessness. If you measure your oxygen levels on the instrument called a pulse oximeter, they are absolutely normal, more than 94%. Okay, so such people can be easily managed at home. And what should you do during home isolation? Well, ideally, you should have a separate room and a toilet, because you don't want to infect others in the house. So you need to be isolated at home. You can't walk around the house like, on other days. You have to stay within your room and use your own toilet. Of course, you must have a mask and wear hand hygiene, and others in the house should also wear a mask if there is a patient in the house. Okay, and all you need to do is symptomatic management. Means if you have a cold, take some cold medicine like cetirizine or Allegra, or if you have a stuffy nose, you can put some nose drops. If you have fever, take paracetamol. Your body ache, take paracetamol. Stay in touch with your doctor, and nothing more is required. No tests, no x-rays, absolutely no CT scans, nothing is required. So it's almost exactly like you had the flu. Exactly what you do when you have the flu. You just stay at home. The only additional thing that we do, because we know we are dealing with COVID-19 and because we know it can affect the lungs, is at home, you keep monitoring your oxygen saturation. So you get a pulse oximeter, and it's available everywhere nowadays. Okay, I'll show you what a pulse oximeter is, and you monitor your oxygen levels. And you monitor your oxygen levels when you're just sitting or lying down. And also you should measure your oxygen saturation after you walked for about 5 or 6 minutes, right? So that's all you need to do. So you measure your oxygen saturation, and that's all you need to do. And of course, if your disease progresses, if you have difficulty in breathing, if your fever is very high and not coming down after 5 days, you cough, right? And then you need to contact your doctor. And of course, if you are like, one of the high risk features that you have, doesn't mean you have to be admitted, but you have to be more careful and monitor very closely. If you're more than 60 years of age, you have high blood pressure, heart disease, diabetes, obesity, or some chronic other diseases, then you need to be in touch with your doctor more frequently. So this is a pulse oximeter, a very simple instrument. Just put your finger into it, and it tells you what is the SpO2, that is a pulse oximeter saturation, the level of oxygen in your blood. It should be more than 94, 95%. And you do it 3 times a day at rest and after walking for 6 minutes. If it is 94 or below, or falls by more than 3% after walking, then you need to just get in touch with your doctor. But that's all you need to do if you are at home. Who should get admitted to the hospital? Well, if you've got what we call as moderate COVID-19, that means you have symptoms of fever, cough, you are a little breathless, patient is a little breathless, and the saturation is now less than 94%. Okay, it's more than 90, but less than 94. So it's not less than 94. And your respiratory rate, so you can count how many times the patient is breathing per minute. And if the respiratory rate is more than 24, again, then you need to be careful, and maybe hospital admission or close watching at home should be considered. So these patients, if they're admitted, they don't need an ICU. You don't have to run for an ICU bed if this happens. What you need is a ward bed. Any ward in the hospital, in the COVID ward of the hospital is enough. And you may need oxygen support, because if your oxygen levels are between 90 and 94, you may need oxygen, or just close observation. What often brings the oxygen levels up is you lying on your stomach, what we call as the prone position. So when you're awake, you just lie prone, you sleep on your stomach. Okay. You will need a chest X-ray and some blood tests. CT scan is not really required. Only if there's worsening, then you need to do a blood test. And because diabetes is a risk factor, you need to measure your blood sugar. And if you're diabetic or if it's high, then you need to control your blood sugar. So this is just, you get admitted in the ward. Now, there's whole lot of discussion about oxygen and shortage of oxygen. And that is because, oxygen comes from these cylinders, and cylinders have a limited amount of oxygen, and these need to be refilled. And if you are not refilled, then, then you run out of oxygen. And that's what's happening in many large hospitals which have cylinder banks, okay, to supply oxygen, or where patients are given oxygen from cylinders. So you can have one at home or in your society, housing society, but remember that these will have to be refilled. And currently there is a problem in getting cylinders refilled in many parts of the country. But I think the situation will get better very soon. Okay, you get a machine called an oxygen concentrator. Now this runs on electricity, and what it does, from the air, it sucks up all the nitrogen into a special substance inside the machine and releases only oxygen. So then you don't need a cylinder, you don't need refilling, it is there all the time. All you need to make sure you've got electricity around the clock, and then you can get oxygen coming from this oxygen concentrator. And many people are buying oxygen concentrators or renting oxygen concentrators, and currently there's a black market in oxygen concentrators also. And then you give oxygen, depending on how sick the patient is. So you can give it through a small, very short pipe in the nose, or through a mask, or sometimes we need very high amounts of oxygen. Then we have a special mask called a NRBM, or a non-rebreathing mask, which is a mask which is fitted over here. So this is how you sort of give oxygen. What medicine should be given to patients who require oxygen or this level of moderate COVID? They need drugs. Now, remember we said that the lungs get affected, it's because the immune response is going a little excessive. So you need to tame it down. And the drugs which tame the immune response are steroids, right? And you've heard of steroids. And there was a very large study which was done in the UK called the recovery trial. And they found that dexamethasone, Decadron or Dexona, which is available, very cheap drug, like Dr. Parekh told you, only 6 milligrams, a low dose, You see, if you give a very big dose, you produce too much suppression of the immune response. That is bad. You need to produce a little immune suppression so that you just slow down the immune response. You don't have to eliminate it completely, and you give it for about 10 days, and that has been shown to really work very well. There are other steroids, and if you're in a hospital, then maybe they'll give you some intravenous alternatives, but the best data and the best evidence that we have from studies and trials is for dexamethasone. You also give blood thinners or the anticoagulants so that because COVID-19, we've seen that, it tends to produce blood clots, not in small vessels as well as in large vessels in the body. So you need to prevent excessive blood clots from happening. And so you need to give blood thinners in patients with COVID-19. So any blood thinners should be given to these patients. So oxygen, steroids, and blood thinners, that's all that you need. Please remember, steroids, like I said, are a double-edged sword. If you give them in the phase where the virus is multiplying, means when you give it early in the illness, okay, then the virus is multiplying. If you suppress immunity at this time, your virus will just go completely out of control and the patient will get worse. And I know it is unfortunately happening that in many sort of descriptions that we see, patients are being prescribed steroids the moment they get a positive PCR in the hope that they will prevent further disease from happening. But that is not going to happen. Steroids will never prevent further disease. Steroids are there to be given to tame the immune response when it is going out of control. And so you need to give it a little later in the course of the disease and only in patients who require oxygen, right? So because that correlates with the severity of the immune response, the requirement for oxygen. So should never be given in patients who do not require oxygen. Okay. Now, so if you give it in patients who do not require oxygen, then it's harmful, and so under medical supervision only they should be taken, and they should be prescribed at the right patient at the right time. Please remember that steroids also have significant side effects like a high blood sugar, okay, because they increase the blood sugar, and therefore in diabetics, the sugar levels have to be very carefully controlled, monitored, and controlled in patients who receive steroids. And like I said, they suppress immune response, and therefore other infections can happen. And we hear all these black fungus reports and all we are seeing in the press. Possibly some of them, we don't know for sure, are related to prolonged and large doses of steroids which have been used in some patients. Okay, so high doses or prolonged doses can increase the risk of fungal infection, especially in diabetic patients who are uncontrolled. Okay, so please do not think that steroids, the moment I'm diagnosed, if I'm taking steroids, I will prevent anything further. You can actually make matters worse if you do not give steroids at the right time. Okay. Unfortunately, a very few % of patients will progress to what we call as severe COVID-19. Here they are breathless, they're very breathless, their saturation is less than 90, their respiratory rate is more than 30. So they are actually, you can see them panting when they are breathing. They don't respond to the simple oxygen measures that we spoke about. And they have to do an X-ray. There will be a lot of pneumonia on the X-ray. They may also have other complications like low blood pressure or heart or kidney failure, and these patients need to be in the intensive care unit. So these patients must go to an ICU where they will get advanced respiratory support, and we won't go into all the advanced modes of respiratory support. They will need frequent monitoring with serial chest X-rays, blood tests, and sugar control. So these are some of the advanced respiratory supports that we can give. So this is called high flow nasal oxygen, a special machine which gives heated gases, and it goes into the nose. And you can give a high amount of oxygen at a high flow rate so patients are comfortable. In some patients, you can actually avoid getting intubation and so on. Otherwise, you can require a ventilator, which we call as non-invasive ventilation. So you put a face mask on the patient, a special mask, and you connect to the small portable ventilator or to a proper ICU ventilator. And this is what we call as non-invasive ventilation. Or you need an invasive ventilation where you put a tube into the patient's throat and connect to a ventilator. And this is for the most seriously ill cases in whom oxygen levels don't come up with standard oxygen or with high flow nasal or with non-invasive ventilation. These patients will require intubation and ventilator. So when we talk about ventilator, this is what we are talking about. Okay. Now, and in what medicines do you need? Dexamethasone again. Sometimes some people may prescribe slightly higher doses, but otherwise it's the standard dose of 6 milligrams. That is the recommended sort of thing. And you need blood thinners, again in the same doses. And if the patient has infection and what we call as sepsis, then antibiotics. and the usual ICU management. Okay, so you can see that as far as oxygen support is concerned, as the severity of disease increases, you move from simple oxygen devices to high flow nasal or BiPAP or non-invasive ventilator, and in the most serious cases, you need invasive ventilation with a tube into the throat in the ICU, right? So you can shift from ward to, say, a semi-ICU to a full-fledged ICU. Please remember, the ventilator does not treat COVID-19. It does not alter the course of the disease. All that the ventilator does is it maintains the oxygen level in the body till the disease dies down, till the inflammatory immune response gets reduced and the lungs recover. So it is only a supportive measure till the other things that we are doing help the patient and the patient eventually recovers. It is very easy to buy ventilators. The center may supply 1,000 ventilators to different parts of the country. You can get donations of ventilators from different countries. But to run a ventilator, to manage a sick patient on a ventilator, you do need trained doctors, trained staff, trained nurses, trained paramedical staff. And today is Nurses Day, International Nurses Day. So I think this is one place where we recognize the value of skilled nursing is in the ICU in patients who are on ventilators. So it is something which is not easy to generate in the course of a pandemic, to generate trained manpower. So that's a challenge. Even if you get ventilators and you do have oxygen, you still need trained staff to handle these patients and these machines. Now, COVID-19 is a little more dangerous than the flu, like I mentioned, not just because it causes pneumonia and oxygen levels to drop. It affects other organs. That clotting which happens, it affects other organs. You have the ACE2 inhibitors in other organs. So you get inflammation of the heart, which we call as myocarditis. The heart doesn't pump effectively. The clot in the coronary arteries can give you a heart attack or a myocardial infarction. You can have rhythm abnormalities. You can get a clot in the pulmonary vessels or in the lung vessels, and you get a pulmonary embolism, which can cause can cause death if it's a large. So you can get a stroke in the brain. You can get kidney injury. Limbs can get clots, and the limbs can get gangrene. So you can get, but please remember, don't panic. These happen in a very, very small percentage of patients, and with good supportive care, we can either prevent or treat many of these complications. Now, I've not talked about any of the Sanjeevanis that everyone is talking about. Everyone is worried about remdesivir, and it's in black market. There are people are hoarding it. People are fighting for it. It's out of stock because, why have we not talked so much about remdesivir? Remdesivir is useful, but it is not the Sanjeevani, right? It is not the magic bullet. It does not cure COVID-19 in many, many patients. It is useful in some patients. Right? It is useful in patients of moderate to severe disease. So if you're asymptomatic, you've got mild disease, you're good enough for home isolation, you absolutely do not require remdesivir. Okay? Even if you have moderate disease, if you don't require oxygen, right, or if you require very little oxygen, you probably don't require remdesivir. You remember, the virus has to be present. So the virus is present in the body only for the first 5 to 10 days. So after 10 days or after 1 week, it's probably of no use. Right? So you have to give it early in the course of the disease, and if you require oxygen. If you're so sick that you require a ventilator, it has been shown that it doesn't work. So it's there required for a few patients. And in the patients in whom it works, it reduces the duration of illness, but it does not reduce mortality. That's not been shown as yet. Okay, so it is useful, but it's not the great magic bullet that we think we have. It is not. Okay, it works in a subset of patients, and it has to be given under medical supervision. It's an intravenous drip which has to be given for 5 days. So again, it has to be given in a hospital setting in some sort of patients. The other drug in the black market is tocilizumab, right? So this is a drug which suppresses the immune response tremendously. It reduces the levels of substances in the blood which amplify the immune response, and therefore it was used to subdue the inflammatory response, the immune response. Now, and like Rajesh Parikh mentioned, there were some studies which suggested it worked, some which suggested it didn't work. Recently, you've got 2 trials which suggest that it may work in some patients. Okay, so it has to be given when severe disease sets in and within 24 to 48 hours of onset of severe disease or ICU admission. So in mild disease and moderate disease, it's probably not very effective. If the patient looks like he is not responding to high flow oxygen or may require ventilation, that is the time you need to hit it. So the timing is very crucial, and that is where the judgment of the doctors counts. The timing when to give it. Okay, there must be signs of more inflammation, right? If the patient doesn't have signs of inflammation, the blood tests do not reveal significant inflammation, it's probably not going to work. And of course, the patient should not have to be getting worse. They're getting steroids, but they're not improving. Heading towards non-invasive ventilation or intubation, that's the time to give it. And remember, it causes tremendous immune suppression. So patients can get secondary infections after that, but that's something that risk and benefit has to be balanced in some patients. So please remember, again, this is not a magic bullet, not a Sanjeevani, useful in a certain small group of patients. Nothing to say that, if this is not available, we are not treating patients. You cannot treat a patient. I don't think it's that kind of a drug. Plasma, as we mentioned, is not really useful. If at all, it has to be given very early, not late. Patients are saying, oh, my patient is dying now, let's give him plasma. It doesn't work that late. If at all, it has to be given early to take care of the virus which is there in the body. And again, there are lots of problems, whether the plasma that is donated is good enough, does it have enough antibodies? There are lots of technical issues with plasma. So again, it's not really recommended, and trials are not encouraging, and plasma is not shown to be useful in trials. This is the cocktail, which President Trump, the ex-President Trump received when he got COVID. And this has just been approved in India. It is going to be horribly expensive. Again, it has to be given early because that's when the virus is replicating. And so far, it has not been shown to reduce mortality, but it does reduce hospitalization. So it can prevent progression of symptoms. So it has to be given early, horribly expensive, just being used. Not many of us have experience with this drug. Maybe Hemant has experience in the United States. Okay, many drugs have come and gone. Many are being used, some without good data, some on the basis of hope, some on the basis of despair, some on the basis of desperation. But all these drugs are, all we can say is that either there is no good data or there is no good reason to use these drugs. And if you're not getting the drugs, please don't think that you're not getting the right treatment. Okay, if these drugs are given, someone believes in them, has hope in them, okay. But if they are not being given, that's absolutely fine. And most of these drugs we are not using in our hospital as well. And some have been shown to be positively not useful in many trials. So including azithromycin, hydroxychloroquine, all these have been shown not to be useful. For some, these are being used very, very much. And I know that they are being used, but the data on that is not very good. It's still coming. Hopefully we'll see, we'll have more data to decide whether it's definitely useful or not useful. But these are being used, but the data on their use is not very good. And some drugs are still being tried out. We'll see and hope that we get some good treatments eventually. So I just want to leave you with one last message. So if you have 1,000 patients with COVID-19, okay, 80% will be asymptomatic or mild. 170 will be moderate, right? So that's about 17%. They will just require a little oxygen and they'll get better. A few, 3% will have severe in the sense they will need lots of oxygen. Okay, only 6, that is 0.6% will require a ventilator, will be seriously sick enough to require a ventilator. Okay, and overall, only 1 to 1.5% will die. Okay, so don't, now, when you have a country when 5 million, 50 million people have been affected, this even 1% is a large number, and that is the tragedy that's happening. But please remember, the odds of you not doing well are very, 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 very small. We can do a lot, but the main thing, and my sincere thing is, prevention is better than cure. And we've got a very simple prevention: wear masks, get vaccinated, wash your hands, don't unnecessarily socialize, don't gather in groups, don't create crowd. If we can do that, we can beat this sooner rather than later, right? And the best supportive care, best treatment is supportive care. No fancy drugs, basic care, oxygen, steroids, blood thinners. All the so-called Sanjeevanis are useful in only very select patients to be decided by your doctors under medical supervision. Thank you very much for listening. And we'll be happy to take questions at the end of it.
Thank you, Jigishu, for a very well-informed management of treatment for COVID patients. I am sure it would be very helpful for people who have already got COVID, or for help and precautions. It's very informative and in detail. And a lot of people have started to appreciate also the initiative of the presentations of Dr. Rajesh Parekh and Dr. Jigishu Divekya. Moving on to our next speaker, Dr. Hemant Shah. His current position is Clinical Professor of Medicine, Wright State University, Boonshoft School of Medicine, Dayton, Ohio. He's a Medical Director, Intensive Care Unit, Kettering Medical Center, Kettering, Ohio. He's a Medical Director, Respiratory Services, Kettering Medical Center. He's a Medical Director, Critical Care Services, Troy Hospital. He's President and Managing Partner, Pulmonary Medicine of Dayton Incorporated. Past Chief of Staff, Kettering Medical Center, Sycamore Medical Center. He's a Medical Director, Kettering COVID Critical Response Team. He's Board Member and Treasurer, Kettering Physicians Alliance. He has been educated in Mumbai at University of Mumbai, and his medical degree is from Medical School St. G.S. Medical College from 1979 to 1985. He has been as a resident internal medicine at New York Health Science, Brooklyn, a fellowship pulmonary medicine, State University of New York Health Sciences, fellowship in critical care, State University, New York Health Sciences, assistant professor of medicine and educator, internal medicine at SUNY, Brooklyn, New York, assistant professor of medicine, fellowship educator, pulmonary at Virginia Medical Center, VA Medical Center, Brooklyn, New York, clinical professor of medicine, Wright State University, Boonshoft School of Medicine. His certifications are American Board of Internal Medicine, American Board of Internal Medicine, Pulmonary Medicine, and American Board of Internal Medicine, Critical Care Medicine, American Board of Internal Medicine, Sleep Medicine. He's a certified physician executive, American Association of Physician Leaders, American College of Physician Executives. He's got a medical license in the state of Ohio. His current and past administration responsibilities, committees, and other activities are: he's past Chief of Staff, as mentioned earlier, Kettering Medical Center, Medical Director for Intensive Care Unit and Respiratory Services, and past member of the board, Kettering and Sycamore Medical Centers. He has chaired a lot of committees, including the Medical Record Committee and CQRC Kettering, Ohio, Pharmaceutical and Therapeutics Committee, and many more.
Shashank, if I may, I think in the interest of time, the audience would like the Q&A. So I'll try and get my presentation. If you want to just,
I would appreciate that.
Yeah.
Okay, then since Hemant has cut down on his I was not even halfway through his illustrious biodata, I would give the mic back to Dr. Hemant Shah for his guidance over this pandemic that is ongoing across the globe. Thank you very much, Hemant.
Thank you, Shashank, and thank you for the kind words. But, this is a tough act to follow with the presentations that were just superb by Rajesh and Jigishu. I have little to add. Just a small housekeeping. If folks that are not needed, if they can turn off their videos, like I see Subramaniam Iyer and others, that would help the audience not get distracted. And you'll have to excuse me, I apologize, because I've given the slides to India, and I'm going to try and run it from here, but I'll be saying, next slide, etc. So I'll try to keep it short and sweet. So, this is some of my friends. Shashank was actually taking this picture, but there is Jigishu, to the right of me, I'm in the red checkered shirt, and there is my good friend Sharad and others. And there is my mother, just January of last year, when I came to run the Mumbai Marathon. And as Rajesh showed at the beginning, the world has changed since January. Next slide, please. So what I'm going to try and do in as short a time as I can is to just try and give you an overview of how things look from the United States. So I don't need to tell you that India is just exploding with cases. The daily total has exceeded 400,000 now, I understand, for over 2 days. And the deaths are just unimaginable. Next slide. But I also wanted to to show you that the United States, despite being the wealthiest country with the highest GDP, with the most resources, had our own quagmire, had our own nightmare between November and January. And you see we had reached 300,000 cases. Next slide, please. So this is just some comparison. Of course, the numbers are clearly underreported. I recognize that. But even let's take it at face value. India, as of yesterday, had 22 million cases. The US had 33 million cases. And if you go down, the deaths in India are half as much that of the US. Agree with the underrepresentation. But the deaths per 100,000 was much higher in the US, despite everything that it had. So yes, India is living through its nightmare, but we had our own nightmare. So next slide, please. And this is for my local hospital, where the number of cases was tremendous through this November through December period. And we in the intensive care saw most of these patients. We saw everyone on the ventilator. CRRT stands for dialysis. So many people who were on dialysis. But just to emphasize what both Doctors Parikh and Devetia said, even in the patients coming to our ICU, over 90% survived. Even those who were on the ventilator, there were a good number, over 40% survived. So there is significant hope. We are trying to do this to avoid panic. Next slide, please. So this is just a glimpse of what we went through when we had our surge of patients. Using the various available literature, we had what we call a surge staffing and surge planning. So we had one critical care doctor, and underneath you can see there are 4 different pyramids, and at any time we were able to take care of 96 critically ill patients from one critical care physician. Recognize that we had a lot of help from other physicians, nurses, as Jigishu pointed out, the Nurses Week, they are just incredible. Respiratory therapists, everyone really contributed. So, my message is this will take all hands on board. Next slide, please. So we had our own planning. So we set up a command center that included top administrators, nursing, all kinds of physicians, intensive care experts, infection experts, even people from the lab. Respiratory therapy were important, even pharmacy, the drugs, and finance. All these were very important. We went down to the sweepers, the housekeeping people, because they're important to keep everything sterile, to turn the beds over and make them healthy for the next patient. We had quick setting of policies, how we would handle the bed, how we would anticipate the need. Where there was shortage, there was definitely shortage. At many times, we were short of ventilators. We were short of very significant medications and PPEs. So yes, the situation is different, but we went through some of this on our own. And there were daily debrief sessions, half an hour with rapid identification. Well, what is the problem? Who is going to manage it? How it is going to be managed? And whatever you need, let us know, and we fix what we can fix. We had significant cooperation with local authorities and even state authorities ourselves. Next slide. And to mention, what Rajesh showed at the end, it was never easy. Next slide, please. We had our own stresses. We had worked long hours. Yeah, next slide, please. And we have significant advantages in the US. Clearly, we had enough oxygen, we had beds for the most part, we had medications, qualified doctors, nurses. The system was overwhelmed at times in many areas on many days, but for the most part, it sustained. We definitely had our own politics, but for the most part, people were accountable and got things done for the good of the patient. The message that I want to send again, was Jigishu and Rajesh said, is that panic is not going to help. The only way out, as Jigishu said, is if we can keep the numbers down, that don't need to come to the hospital, let the hospitals do what they have to do. That is going to be the way out. There is no magic bullet. There is no Sanjeevani. And there should be some fundamental trust in your doctors, whoever you choose. I get calls every day from people, from my colleagues, from my families. They have already spoken to 20 physicians there and another dozen here, and then they're doing a hodgepodge of things. I don't think that is going to help. I don't think that is going to work. Next slide, please. So, while India is facing the greatest crisis it has ever seen in living memory, next slide, there is a way out. The pandemic can be controlled. Lives can be saved. And I'm not here to preach to you. You will have to come India with its own solutions. People internationally, including us expats, will definitely help in every way we can. In fact, this conference started because I was coordinating a group with the help of API, American Association of Physicians of India, and we are consulting with physicians, we are consulting with patients in India. And I said, well, why not do it amongst our friends? So we started as a St. Xavier's project. We are all Xavierites. And, I cannot thank Sabarimala, Ayyappa, Seva, Samajam enough that we are going to need people like you to really help significantly. So on a national level, I think the country will have to acknowledge the shortfalls. And once again, you have to trust your experts, the medical experts, the IT experts, the business, the logistical experts, community leaders. We have to come up with honest opinion, no political biases, and act decisively. Some of the things may be difficult. We will need great coordination at the local level between the national and the hospital level. You will have to have your own doctors, your own hospitals and administrators come up with their own command centers, identify your problems locally, and then deliver help in the most effective manner. I cannot thank people like Jigishu and Rajesh for what they're doing and hundreds and thousands of other physicians. It pains me when I see healthcare people get beaten up. They're just trying to help. So while this doesn't happen everywhere, it sends a wrong message. The public has to be calm. They cannot panic, especially in the mild cases, which are the majority. This we have shown again and again. You have to trust the science, trust your physician, avoid unnecessary tests, avoid unnecessary treatments. And the public themselves, like Sabarimala, will have to go out and help in every way they can. And above all, at this point, vaccines. Next slide, please. Next slide. So, this has been shown, but vaccines are going to be the way out. And I took this from an Indian publication, whether it is Covaxin or Covishield, the effectiveness is excellent. As Dr. Parekh showed earlier, for the WHO, even if you get over 50% effectiveness, and we have significantly more effectiveness, go get your vaccine. So what if there is a little pain, a little ache, a little fever for a short time? It is a lot better than a tube down your throat with a ventilator breathing for you. There is no excuse, if the vaccine is available, for you not to get it. Next slide. So, yes, we have a long ways to go. Yes, there is vaccine shortages, and yes, there are problems with distribution, but in your own way, as and when available, please get vaccinated. Next slide. So, just to emphasize what the previous two speakers have said, the majority of people, over 90%, overwhelmingly, will have mild disease. Do not panic. There is no need for medications like antibiotics or antivirals or steroids or blood thinners when the disease is very mild. maybe just some paracetamol, as Jigishu said. You really don't need blood tests. I cannot tell you the number of times people have told me, I have this brother of mine, this cousin of mine who's sick. Can you review the CAT scan? Remember, before you look at the CAT scan, you have to evaluate what is the status of the patient. Just remember that CAT scans are harmful. One CAT scan is roughly equal to something like the radiation of between 100 and 300 X-rays. If you keep on getting it, I'm afraid down the line you're going to get lung cancer. So just remember those things, do it when it is appropriate. Eat a balanced, healthy diet. I know this group emphasizes a good, healthy diet, good exercise. I do preach yoga also. I practice it, I preach it, it is helpful. There is no proof that some of the other things like steam inhalation work, but if it feels good, there is no harm in it. Keep in touch with your doctor. And if your situation or your loved one's situation worsens, leave it to the experts. Don't do a hodgepodge of treatments from multiple physicians. That's what I'm going to tell you again and again. In all these chat groups where I'm giving advice, this would be my summary slide to them for 90% of the people. Next slide. So there is a period of time when after you recover, there are these group of symptoms. There can be this fatigue, there can be persistent cough, there can be shortness of breath, headaches. And Rajesh, being a psychiatrist, will tell you the number of people who have significant anxiety and depression. But for the majority of it that is mentioned in the first line, don't keep on taking more medications. They don't work and they may cause harm. We emphasize exercising even when people are in the mild stages. I'm not talking about the moderate or severe stages. So you don't really have to do complete bed rest. So these are going to be the few simple things that I'm going to tell you that work for us. I have had my own family pay the price and get COVID. And this is the same recommendations that I'm going them as I'm telling you. Next slide. So this is not going to be a quick fix. This is going to take time. It is going to take a Herculean effort, but it can be done. And my final slide. So going back to what Rajesh said, if there is anything that we are going to learn from this, is not to plan for the next COVID, not to plan for the next wave. We will do that. We will have to do that. But we have to plan for the next disaster. We have to improve our infrastructure. We have to improve our hospitals. We have to improve our healthcare delivery. We have to improve our health education for the public. And that's what I'm here to tell you. And with that, I'm going to end, and I'll be happy to answer with the panel any question answers that may come. I hope this is helpful. Thank you.
Thank you very much, Dr. Hemant, for concurring with Dr. Jigishu Divetia and Dr. Rajesh Parekh, and also sharing your personal experiences as a critical care ICU head and also a pulmonologist at the same time. Thank you very much for the three panelists. I would just like to conclude by saying it is important to stay well informed about the coronavirus pandemic and be proactive. But it is equally important that we continue to find hope to support us through this difficult time and make our fears and despair more manageable. The wings of hope carry us soaring high above the driving winds of life. It is not the time to blame anyone. It's a pandemic. It is time to make a promise that I will not get infected by the virus. And if I get it by any chance, I will not let anyone get infected by me. Today is Mother's Day. And it is highly important for us to appreciate the panelists and the doctors and the paramedical staff, the nurses and other people around the world, and acknowledge them for their unconditional, tender, loving care that I have been imparting during this COVID crisis across the globe. I do thank the panelists and everybody for this wonderful presentation. I now request our National Secretary and Prabhari of the Kokan Pranth, Mr. Murugan Thevarji, to say a few words.
Thanks for organizing wonderful things, particularly and knowingly, unknowingly, and sometimes most of the time, due to panic, we get to watch a lot of new channels. But the other side, whether we welcome or not, also the WhatsApp messages keep on pouring, which is right or wrong, and the layperson is not able to understand that. And when I was trying to attend this, and it was a really sweet surprise. And the many professional doctors, the way they explain that, even it clear a lot of things, and we don't get opportunity now and then, because when we watching the channel also, there is also limitation. And every doctor they given very simplified, particularly they have simplified a lot of very useful information, and kind of eye opener, I can say this. Listening these all the things, I feel like doing such a thing for more people where we can reach. It makes a lot of difference. Like, Mr. Verma and two other doctors also said that the community's participation, it makes a lot of difference and making things a little more clear, and highly appreciated. Such a COVID time, you have removed your valuable times. All the doctor, every minutes it count for you all. We are really respecting all your contributions socially, and particularly the frontline workers and all the paramedicals, everyone, the way you people are guarding our country, such a crisis time. Even you are not able to taking care of yourself also at the time, you are not able to give a time to your family also. But still, the contribution from your all, it is highly respectable. It will remember lifelong every patient of COVID. Highly salute. Swami Saranam.
Mr. Shah, I have one question. Can I ask?
Yeah, please.
Please go ahead.
Okay, thank you very much, sir. My name is Prakash Vyavahare. I am from Indore. I am 67 years old, retired professor. I must congratulate all the doctors, must thank them actually for making very nice presentation and explaining that it's not necessary to get panic. I have one question. The question is, myself and my wife were infected in November last year. And then we also got first dose of vaccine in the month of April. So can you comment on the chances of getting infected or something? I mean, we are following social distancing, masking, exercise, food, everything. But any one of the panelists can comment on such type of case.
So, can I take that, Shashank?
Yeah, please go ahead.
So, Professor Vyavahare, so you've recovered, you had COVID in November, and you also have taken the vaccine. So I think that's a great thing that has happened. So you already had good antibodies to the virus because of your natural infection, and you already got a boost now because of the vaccine. It means that it does not mean that you will not get the virus at all, right? You may still get the virus. That is why even if you've taken the vaccine, even if you've taken both doses of vaccine, it is still essential that you maintain what is now called COVID appropriate behavior. That is, you wear a mask and others around you wear a mask, when you're outside. The usual things, don't go out unnecessarily, wear a mask, wash your hands, maintain social distancing. The value of the vaccine, the vaccine, when we say 70% effective, the one which we get, is that 70% of patients will not get an infection, okay? They will not get the disease. 30% could still get the disease in spite of the vaccine. And we are talking of full vaccination, okay? The advantage is, there are 70% chance that you will not get it. But the good thing about the vaccine is that even if you get an infection, even if you get the disease, right, God forbid, but even if you do, you will not, the chances of you landing up in hospital or getting severe disease are almost 95% less. So you are protected from severe disease almost certainly, but we cannot say that you are got protection from getting a new infection. Although in your case, it seems unlikely, but it's not impossible. So you have to continue to take care. You and others around you need to continue to take care. And I think masking is a very, very simple thing which everyone must do. You know, people salute doctors and frontline workers and they clap and they bajao thali and all those things. I think the best appreciation would be if you can reduce the work of doctors and the load on hospitals by doing simple things like wearing masks and maintaining social distancing.
Thank you very much, Doctor. The only small last question. I know there are many people who must be asking the question. Can any one of you share one email? Not everybody, but anyone. If I have some question, I can ask later.
I will share my email. You could send your question to me and they would reply. I would forward that reply to you.
Perfect.
शाह साहब आपका मेल क्या है लिख दिया इधर
मैं अभी लिख देता हूँ
ठीक है
I have already put it up. Anybody else with other questions could go on because there are possibly not an issue to manage the questions verbally. Any question needs to be answered?
Shashank, can I ask Shirish?
Please, Shirish, go ahead.
Yeah, any of the doctors could probably answer. This question I posed up for pulmonary embolism. My daughter had a case about 4-5 years ago. She's out of it. There's no medication. But I was wondering whether we could give any of the vaccines or should it be either the mRNA or the other ones? Maybe Dr. Hemant Shah.
Dr. Rajesh, would you like to answer the part on the vaccine that Shirish put up, please?
Could we give any particular vaccine or any of the 2 vaccines is okay? Dr. Hemant Shah?
Yeah, I don't know if Rajesh is the expert, but his mic is turned off. My recommendation is any of the vaccines are fine. There is no, first of all, with pulmonary embolism, there is no contraindication. You should definitely get the vaccine. Second, any vaccine is fine. There is no reason to choose one over the other. The best vaccine is a vaccine in your arm. The sooner, the better.
Thank you. Thank you very much.
Dr. Hemant Shah, there is a question posted on the chat regarding hybrid dosage of vaccines. Is there something called as hybrid dosage of vaccines?
I think it was raised by my colleague, Dr. Shaunak Khandwala, I think in Kenya. Shaunak, can you first, I have an idea what you're asking, but just to be sure, can you explain what you mean by hybrid dosage?
Hi, how are you? It's so nice and so nostalgic to see so many of my school friends and batchmates after such a long time from different parts of the world.
Just so
as
that
SCTR in Eldoret, Kenya.
is a world famous expert as an OB/GYN physician, infertility expert. So very, very reputable, respectable physician. Go ahead, Shauna.
Okay, I meant like this. What I meant was that if you take a first shot of Pfizer, for example, can you take a second shot of Covishield? That's what I meant by hybrid.
So I'll give you my opinion. Rajesh is smiling. Dr. Parikh, go ahead, please. You are still on mute, Rajesh. Rajesh, you're still muted.
Okay, I guess I'm not muted now. I was smiling because I was happy to see Shaunak after such a long time. I was not smiling because I wanted to answer it. But, Shaunak, this is a very interesting question and it gets asked all the time. See, if the technologies are different, okay, if you're using Pfizer or Moderna, which is an mRNA technology, and you're using AstraZeneca, which is completely different technology, it doesn't stand to reason. However, having said that, even as we speak, there are studies underway which are now looking at combinations of vaccines and also the hybrid thing that you spoke of. For example, you take DPT, diphtheria, pertussis, tetanus, all these 3 are mixed together and given to children. So there have been questions raised that because different vaccines act in slightly different ways, would it make sense when we are dealing with mutant strains to combine the vaccines when they're given in one go, or to give one vaccine of one class and another of another? To the best of my knowledge, the results of these trials are not in. So until that time, we are probably better off just taking the second vaccine, which is the booster for the first one that we took.
Just as a joint question, can I ask whether if you have got a single, an infection of full-fledged infection of COVID-19, is it like taking a single shot and then you need only one shot then? Because you are already immunized with that, your antibodies have already come there. Your T cells already memory is developed, so you just need to take one more shot then.
Okay, I wish I could agree, but I don't. The better thing to do is to wait for about 3-4 weeks and take both shots. But I'd love to hear what Hemant and Jiggy have to say on this, or anybody else who has other thoughts about whether you should take just one shot if you've been infected, or whether, as I suggest, you should go ahead with 2 shots.
Rajesh, I agree with you. The problem with natural immunity is we don't know whether it's protective or how long the protection is going to last. So the recommendation is just take your 2 doses of the vaccine as you normally take a vaccine, irrespective of when whether you've got a prior infection or not. So I'd say just go ahead and take 2 doses of the vaccine.
Agree 100%.
Yes, can I ask a question, please?
Yes, please go ahead. Shauna, could you please mute your mic? Yeah, Shwetal, please go ahead.
Yeah, actually, we have taken first dose of AstraZeneca, and actually there is a shortage of vaccine here in Saudi Arabia. So due to that, actually, they have extended our second dose period. So I just like to know that what should be the ideal second dose period, or there should be any time limit, or it will create any complication or something like that, just to get to know.
So in India, we started with an recommended interval of 4 weeks. Now we've extended it to 6 to 8 weeks, and it works. And in the UK, based on data from the studies that they've done, they've actually increased that interval to 3 months, so 12 weeks. So anytime up to 12 weeks, if you can take your second dose, that's fine. And you don't know what happens if it goes beyond that. What I'd suggest you just take your doses whenever it's due. Just go ahead and take the dose.
No, but government has actually refused that they cannot give within 12 weeks time. Actually, my second appointment was booked for almost like 11th week, and they already cancelled now. And on our like Arogya Setu kind of application, now they are showing that you are immune up to 24/9. So they are calculating 6 months from the first vaccine dose.
Oh.
Rajesh, could you please take this question?
Yeah. See, there is some logic to it, okay, because it is being anticipated that the immunity from 2 doses lasts for about 6 months. I don't know if there are any studies done to show how long the immunity from a single dose lasts. Actually, the AstraZeneca thing was an accident. We needn't get into the details of that, of half dose and 1 dose, but it was accidentally discovered that you can prolong this, and that has been proven. That has been shown in studies. In fact, some studies are showing that actually getting it at 8 weeks is better than getting it at 4 weeks in terms of immune response. But to the best of my knowledge, there is no study showing how long the immunity lasts after the first dose. Having said that, you're still better off taking the second dose even after 6 months rather than not taking it at all. And also, the way the science is progressing, by the time you take the second dose, we'll know a lot more than we know today.
I will show you what it is written here. Clearly, it is written that you are immune up to 24/9. I have taken on 14th March the vaccine, So they are showing on my application that you are immune by first dose until 24 September.
The Kokan must have had given you a second
I
dose
think
without
Hemant
you actually
quite
getting
clearly
it.
advised us all. I think Hemant advised us all. Take local advice.
No, I completely agree.
I
And
don't
as
know.
Rajesh is saying, give it another few months and we'll learn things that are new. Things will change, and probably we'll be due for our booster in another 3-6 months anyway. And this booster will probably include coverage for the mutants or the variants, so to speak. So.
Also, nothing really changes. Even if you were to get both your doses on time, you still have to be very strict with your COVID appropriate behavior. So getting the second dose in time doesn't change anything much in terms of your lifestyle. And on the other hand, if you continue with COVID appropriate behavior, then that's also very effective vaccination.
Yeah, correct. But the people like us, actually, the vaccine passport is important for the travel. So that is the most important thing. If the 2 doses have been completed, then the traveling will be easy. Otherwise, it is very difficult. That was the reason. But let us hope that India will be able to supply this AstraZeneca here, and I will get my second dose.
Maybe you can just go across to Dubai. Maybe you can just go across to a neighboring country. You can drive across and see if you can get it there.
Yeah, that is also a good idea. Yeah.
So it will be commercially available soon. So you may just be able to buy it in some countries.
Yeah, okay. Good to know that. Thank you very much.
I mean, there are no further questions at the moment, other than there's Hemant has already got himself.
Sorry, Shashank, can I come in?
Yeah, Shaunak, please, most welcome.
Hemant, this is a question for you, as you are in the US. What is the safety efficacy of Johnson & Johnson, which is giving only 1 shot, as compared to Moderna and Pfizer, which have got 2 shots? Is there a study going on in the US as far as the efficacy is concerned? And of course, it's a prospective study because it will take some time to act and all that. But still, do you have any data?
So we can answer it on 2 levels. One is for the lay people, it is very effective. On a scientific basis, in the studies that were reported to the FDA, the Pfizer and Moderna were 94 and 95% efficacious for preventing infection, and well over 99% to prevent hospitalizations and deaths. As far as the Johnson & Johnson, the study was done later. So there are some people who believe that the kind of patients Johnson & Johnson encountered were sicker because they came during the fall surge that we had. Having said that, the efficacy data on Johnson & Johnson, there was some fudging of data, that's another story that Rajesh knows, is still over 70% for getting infected. For getting hospitalized or deaths, it is still way over 95%. So if that answers your question, and remember, it is one and done. If I were to anticipate your next question about the incidence of the side effects and the so-called thrombosis, almost like a HIT phenomenon, heparin-induced thrombocytopenia type phenomenon, the incidence, at least what has been studied, is 0.007% in a select age group of women between 17 to 42, etc. Yes, as we know more, we will uncover more, but bottom line for the lay public, it's very efficacious and it's one and done. Rajesh, is that fair?
Absolutely. I couldn't agree with you more. But, since Shaunak is a tough customer, he needs details. I'd just like to tell him that the trial was paused. Maybe that's why you're concerned about it. The trial was paused for a while. All the data was reviewed. And I don't remember, it was just a question of days before it was started again. So when they reviewed the data, it exactly tallies with what Hemant is telling us.
In fact, oral contraceptives give more chance of thrombosis than the vaccine would, I guess.
So if you were to ask again on a pure scientific, again, for lay people, yes, thrombosis. But for Rajesh and Jigishu, they'll tell you the thrombosis that you get with COVID is actually different. There is not the classic thrombosis that we are understanding from the past is you get a clot formation, so-called workout stride, if you remember your medical school days, and the clot breaks off from legs and goes to the lungs. That is not what is happening in COVID. You have endothelial damage, and that sets up an in situ thrombosis, which is somewhat different. And so there are some in the scientific literature that will tell you that yes, while thrombosis is higher, it is not that cut and dry, clear cut that blood thinners necessarily prevent them and it could harm them. But again, that's a different level of discussion. Would you agree, Rajesh and Jigeshu?
Yeah. I'd love to hear what Jiggy has to say. But there's one other thing, Shanak, and this sometimes people forget. In any decision, there is a trade-off between risk and benefit. And somehow when it comes to vaccines, people are overemphasizing some rare things that they've read which are unproven and considering them as risks, while completely omitting the benefits of vaccination and completely ignoring the risks of not getting vaccinated. So quite clearly, there's no comparison. I mean, the risks of not getting vaccinated likely to give you far more thrombosis than by getting vaccinated. And another thing people forget, which I like to remind them, that vaccination has a history of 200 years. Vaccination has wiped out polio from the planet. Not from the planet, Afghanistan and Pakistan still have it, but smallpox is completely wiped out from the planet. So time and again, vaccination has always worked, and with rare instances where it hasn't, and that those vaccines were withdrawn. And in the current pandemic, all over the world, vaccines are working. Hemant showed us that impressive graph, of the 0.02% and 0.03% likelihood of getting infection after the 2 doses. So people don't weigh this. They're only focusing on, 1 in 100,000 possibility, ignoring the benefit and ignoring the risk of not getting vaccinated.
Yes. So Rajesh, I agree 100%. I mean, I think there's no question, and there should not be this debate. The thrombosis that you hear about are so rare, and like Hemant said, it's not a predictable mechanism. It's a funny sort of mechanism as far as from whatever we understand so far, it happens in a very rare subgroup of patients in a very rare number of times. And for all those who say that, because of this incidence of side effects, I don't want to get vaccinated, those people should not be driving a car. They should not be crossing the road. They should not be taking a flight. And like for Shaunak's benefit, they should not be taking oral contraceptives either, because the failure rate of oral contraceptives is much higher than the risk of getting a problem with the vaccine. So just go ahead and take the vaccine. The benefit far, far, far outweighs the risk. I mean, there should not be any debate on this issue.
Gigi, Shaunak is totally against oral contraceptives. He wants everybody to have more and more babies.
No, I meant the risk of thrombosis with oral contraceptives is much more than the risk of thrombosis with the vaccination.
Yeah.
Very well said.
I didn't say failure of oral contraceptives.
Yeah, but even that failure rate is much higher than the risk of thrombosis with vaccines. So both ways, vaccines score over oral contraceptives.
Let me take this opportunity to go with what question was actually asked by Mr. Girish Nair about D-dimer. Just like Jigeshu said, I just see there is too much indiscriminate use of D-dimers. So if people are listening in the audience, the D-dimer is a very specific test with very specific indication, mostly for hospitalized patients. And this should not be done for the most part in outpatients who are up and around, walking around. And second, blood thinners have their risks. People bleed. If you have significant blood thinners on board and you tumble down the steps, you can have major problems. You have a car accident, you can bleed to death. So as Rajesh said, the risks of what we think we know, we ignore the risk of what we don't know.
And, I might just add one thing. I mean, Hemant and I not only went to the same school, but we also went to the same medical school, KM Hospital, GS Medical. And I'm sure you'll agree with us, Jiggy, that all our teachers, our senior clinicians, sadly, some of them are no more, taught us that do not look at the disease, look at the person who is carrying the disease. And do not look at the test, look at the disease and the person who's carrying the disease. So most tests, with rare exceptions, are meaningless in the absence of a clinical evaluation. But today, people are getting tests done and then, just deciding what they should be taking without correlating it with the clinical condition. And that also poses greater dangers than oral contraceptives or anything else for that matter.
Yeah, to piggyback on what Rajesh said, I cannot tell you the number of times I get messages on WhatsApp with streams and streams of blood tests. And my simple question is, how does the patient look? And I don't know if it is, but Rajesh and Jigishu or anyone can tell me, why is it that they don't allow cell phones in the hospitals or patient rooms? Because if I can have a 30-second video clip of what the patient looks like, how he talks, how he walks, I can be much more helpful than streams and streams of tests. Any reason why they don't allow cell phones?
I don't know.
Initially, sorry, go ahead, Jiggy.
Go ahead, Rajesh. Sorry.
No, initially it was believed that cell phones are fomites. Now, fomites are objects which carry viruses. But, if cell phones can carry viruses, so can stethoscopes. And so can ties, which have been shown to be fomites, for a long, long time. So I think the idea of barring the cell phone was that the cell phone comes from outside, is handled by many people. I think that was the original idea. But after that, I'm not sure. I'm not sure what the continuing rationale is.
I think, one of the things that we faced in this pandemic or in this is communication with patients and families is very difficult, because patient is isolated, families are quarantined, and the cell phone is a lifesaver. I mean, in the sense it maintains that contact between the patients and the families. And, sometimes patients are sick, so they can't speak on the cell phone or we can't operate their cell phone. So we actually have a cell phone in the ICU in which we actually do a WhatsApp call or a call, and we actually beam the patient's condition to the family members, So I think not having a cell phone doesn't make much sense, and I guess they should be allowed. There are patients who are not in a position to operate them sometimes, especially in the ICUs. But for them, we've got our own ICU cell phone, which we use for communication between patients and families. And so the breakdown of communication was a problem we faced initially, and that still remains a problem in some sort of at times. And cell phones, I think, are a fantastic tool to fix that problem.
So Jigishu, hats off to you. I wish, because I get calls from, I'm sure like you do, from all over the country. And one of the biggest challenges that I'm hearing is that the families are not able to communicate. And what you're doing, Jigishu, at your institution, or maybe Rajesh, to allow the families to communicate either by their device or your own device, is going to be very helpful. I can tell you that my personal experience in the ICU, it would be very difficult thing that we did, because not only were we managing the patients, but we spend a considerable time of our day or even night contacting the family and keeping in touch with them. And that, I think, helped significantly. In fact, we had surrogates. We even had many people that would help in the process. But keeping the family informed, I think, is a huge thing. And if you're doing it at your institution, hats off. I wish more institutions in India could do that.
Yeah, so what we are doing, Hemant, at Jaslok, we have a time, not only we encourage it, we ensure it. So what do we do at Jaslok? In the ICUs, we have multiple cell phones. There is a time set, like used to have visiting hours, in the old days. So there are hours which are blocked for relatives to talk to the doctor, say between 4 p.m. and 6 p.m. Sometimes that changes if there are emergencies. But there are also time slots planned for each individual patient. So it is planned that each patient will talk to a relative, and we encourage that. And where that becomes even more important is, when some patients are going to be no more, when you sense that they are sinking, it's very important for the family to spend those last minutes with them. So that's the third case, which we call emergency cell phone use. The other two are planned and done on a routine basis. But if somebody is sinking, then the family is contacted, and they get to say their goodbyes and all that, and don't carry the guilt for the rest of their lives.
I'll add that even in our institution, they would not allow, and I really pushed for allowing family members in when patients are so critical that they're dying or I'm putting them on life support, etc. And there are studies that showed that that did not increase at all the incidence of infection as long as the appropriate precautions were followed. So, that's something that might need to be revisited by some.
Thank you, panelists, the three eminent doctors. The informal talk between you all was more informative than otherwise one could get, because this was more practical in all purposes. A relation between the patient and the doctor possibly has been established by all in the ICU in particular. And I now, Rajiv, would you like to say something?
Yes, thank you. I just want to thank Dr. Hemant, Dr. Devadya. I could not even say anything because it's so informative. Only, actually, I got infected with COVID about 3 weeks back. Now, 3 or 4 weeks back, I'm much better now. And the only thing, I have to take blood thinning medicines for a month. I cannot take Ecosprin being G6PD deficient. And the doctor has advised this one, I think it is
Adequate.
Yeah, adequate 5 mg. So would it be safe to take that for a month? Only that a little bit question in my mind. No. That's it. Then I just want to ask you, doctors, because there are so many doctors, doing so many different methods. 2 weeks back, one of my friends is a sister and daughter, my school friend, almost died at home. He reached from Delhi in time. Some very well-renowned doctor gave them steroids and he got those oxygen at home and they have recovered. So this is a small thing that worries me. So I just a question in that. And my CRP was 7, D-dimer borderline, and IR6 was marginally high. From instead of 7 is the limit, it was 9.28. That's the information. Yes. And hello, yeah. Could please somebody throw light on it?
So, were you in the hospital or were you at home?
No, sir, I was at home. I have arthritis. And I just want to tell you, thanks to Dr. Hemant's father who introduced me to yoga, which is actually keeping me alive, We are, that is it. So that yoga thing, our family is into yoga. And I was not in the hospital, we were at home. Me, my wife, my mother-in-law, 88, got infected. She did well because she had already taken 1 dose of the vaccine. She had
and you did not require oxygen or anything?
No, sir, nothing.
And looking at you, like Hemant says, I don't care what your CRP or D-dimer or whatever other test you've done, you look absolutely fine.
Yeah.
So
day by day, my headaches have been reducing. Day by day, my headaches have been it was little, now it is completely gone away. I'm feeling much, much, much better. I'm talking also better.
So there is a bit of a debate as to whether you should give blood thinners. Usually it's given to patients in hospital, but there's a debate whether you should continue it after your discharge or not. And I guess you go by your doctor, whatever your doctor has advised you, and stay in touch with him.
Okay, she told me only for a month, so I don't think it should harm much.
And if you speak to 5 doctors, you might get 5 different opinions.
Yeah, I know.
You go with one doctor. Or whether...
No, I'm really grateful. I thank you all very much.
Hello, Mr. Deranani. Interesting, because I'm actually in the process of, with my colleagues, doing a study on hospitalized patients who got your medication, blood thinner, whether it should be continued, what dose and how long. So right now, we don't know. But if you're not hospitalized and if you're able to walk around or do yoga, that is better than taking your blood thinner, in my opinion.
Okay, Dr. Hemant. Thank you. Thank you so much. Thank you, Shashank. Thank you very much.
Yeah, I think it's time we concluded. Thanks once again for the panelists, and I request Mr. G. Venkateshwaran to propose a vote of thanks.
Hello, friends. It's been a rather very enlightening evening for all of us. I would like to first of all thank all the panelists, all the doctors, Dr. Rajesh Parekh, Dr. Jigishu Devatia, Dr. Hemant Shah for enlightening us and giving us a very comprehensive view of COVID and what are the various clinical management methodologies that are being recommended by all of y'all in all the countries. Thanks a lot for being with us and enlightening us for the same. I would also like to thank Dr. Shaunak Khandwala as well as all the other doctors who have informally participated among various participants who kind of logged in from all over the world to be with us and to patiently listen to the detailed presentation given by our panelists. Thanks a lot once again to all the members and key personnel of Sabarimala, Ayyappa, Seva, Samajam, Kokan, Pranth, and especially to you, Shashank, for doing all the prep work and coordinating all this and making this possible. We would like to have many more sessions like this in the near future, which will enlighten all the members of SASS as well as other such organizations. Thanks a lot. Thank you.
Thank you, panelists. Nothing could have happened without your support. Please continue supporting such events.
Thank you.
Thank you.
Thank you very much. Good night.
Thank you very much.
Thank you.
I'm Gosham.
Thank you.
Sundarlingam ji, Sharanam Gosham.
Okay. Swami
Sharanam Ayyappa.
Thank you very much. Swami Sharanam.
Swami Sharanam.
Swami Sharanam.
Swami
Thank you,
Sharanam.
everybody. Thank you very
Thank you,
much.
everybody.
All
Thank you.
Shashank Shah Saab, thank you very much for organizing this event. Okay.
Thank you for your support. Thank you very much.
Bye. Thank you.
Bye bye.
Take care. Good night.
Bye. Take care.
Bye, Shauna.
Thank you very much.